Our next panel, I'm going to introduce now and ask each of the panelists to come up as I introduce them. In the interest of time, I'm going to try to talk fast like I do since I was raised in New Jersey. I can do that. Our moderator is David Cassen. David's very well known. He's the CMIO of Pascal Metrics. He's also an associate professor of internal medicine specializing in infectious disease at the University of Utah School of Medicine. David, please come on up. Our next panelist is one of my favorite people in the world. His name is Rick Boothman. He is the Chief Risk Officer at the University of Michigan Health System. He's a lawyer, but we'll try not to hold that against him. He's a friend of doctors everywhere. Our next panelist is Michael Cohen. He is the president of the Institute for Safe Medical Practice and has a lot of great knowledge about medication safety. I think many of you have heard Nat Sims mentioned many times. He's a great friend and a wonderful human being. And he is a cardiac anesthesiologist. He calls himself a reformed cardiac anesthesiologist and is a physician advisor to biomedical engineering at Mass General Hospital and associate professor of anesthesia at the Harvard Medical School. Nat? So I just want to remind everybody that our panelists met prior to coming together today and have developed a recipe for how to address some of these issues around medication safety, and those will be addressed during the afternoon session that we have. Medical errors are defined as a preventable adverse event or effective care, and as I think you've heard many times already today, are a leading cause of death in the United States, exceeding the deaths attributable to motor vehicle accidents, breast cancer, and heart failure. They include inaccurate or incomplete diagnosis or treatment, as well as when an appropriate method of care is executed incorrectly. Human error has been implicated in nearly 80% of adverse events that occur in complex healthcare systems. The vast majority of medical errors result from faulty systems and poorly designed processes versus poor practices or incompetent practitioners. So with having said all of that,
people.
How did I do that again?
Yeah.
How did I do that?
Got Narendra and
I'm like
Josh.
retarded. I'm killing the guy. I'm killing the teleprompter guy. I'm killing that guy because he's trying to help me by pausing the thing. Narendra Kini is the CEO of Miami Children's Hospital. Josh Adler is the CMO of the University of San Francisco Hospital, University of California, San Francisco Hospital. I should forget the teleprompter. Just.
We call this running on the fly quickly. Didn't know you were going to be on the panel until 30 seconds ago. Well, welcome everyone. Our session is going to focus on medication errors. Medication errors 25 years ago were the most common patient safety problem in our healthcare system. They remain so today. I'm going to start with a little bit of background, and then we've created a list of questions to pepper our panel. And I want to thank Michael and Massimo for bringing together one of the most distinguished panels in this area I've ever had the pleasure of working with. So we have a whole list of scripted questions for them, and then we will have a breakout session on this in the afternoon as well. So lots of opportunity to learn from these experts. And I'm going to start with just a little bit of background, if I can get the slides perfect to go forward. And my background is going to be drawn from a new report from the Institute of Medicine, Health IT and Patient Safety, a report published last year that summarizes where we are in patient safety since to err is human, and also talks about where we've come in health IT, and then finishes by saying, what can we do to maximize the benefit of improving safety with health IT? So that's where the slides are drawn from and what we're going to focus on, and this will come up again and again in our panel discussions. And that particular report from the Institute of Medicine has now been turned into a federal action plan in response to the recommendations in that report. This was just released, and the public comment period is ongoing. I think, Chuck, we have until February 2nd to give public comments. So this is taking the recommendations in the IOM report, how we can enhance patient safety with technology, turning them into a federal action plan. So both of these reports are available online free. You can get the first one at the Institute of Medicine website, and you can get this one at the Office of the National Coordinator website. I'd encourage you all to read them. They will change the landscape of health information technology as we move down the road to regulation. So let's talk a little bit about medication errors. And this represents work that was done a number of years ago to look at the complexity of what happens when we administer a medication to a patient. And as you can see, this is pretty complex. Starts all the way from ordering, if you will, all the way to administration and then routine surveillance for problems. And you can see that complications in the form of adverse drug events, these are things that actually occur to patients, occur throughout this process, and also medication errors occur throughout this process. And I think the key point here is that not every medication error leads to harm to a patient. What is harm to a patient is what we call an adverse drug event, and that's listed on the slide. And you'll see that a lot of adverse drug events occur in the administration step of medication. And the reason for that is why we have Nat Sims on the panel. Intravenous medication is a risky process, and we're going to talk a whole lot about that. And that's one that we can clearly improve with technology and with other interventions. And if we look at all the technologies that have been thrown at the medication safety issue, you can see there are many. We're going to talk about many of these with our panel. We reviewed these in our Institute of Medicine report. And what I think we've realized is this is a pretty complex process that we've thrown a lot of technology out. Our challenge now is to further optimize and integrate that technology, because just throwing the technology at it does not solve the problem. And I think that's one thing we came back to again and again in our Institute of Medicine report. And we have gotten better at adopting these technologies. This is a slide that Mike Cohen gave us that outlines of all these different technologies we throw at medication safety, the increasing adoption of them in hospitals. So we are making progress here. But just adopting them alone does not necessarily lead to safety impact. So here's an article from a hospital that had put all these technologies in place, from CPOE, computerized physician order entry, to barcoding, to computerized dispensing with robots. And so they'd done all of this, and they still had a very high rate of medication safety problems. And this is one of the things we focused on in our IOM report, and our panel will talk about. What can we learn from the fact that we threw all this technology at things, and yet in a hospital where this was done, we still had a high rate of medication safety problems? One of the reasons for that is what that hospital had put in place in terms of computerized physician order entry did not have all the bells and whistles fully optimized to make sure that this technology was actually improving medication safety. And this has been tested through a standard that Chuck Denham and I and others have been involved in, a safe practice for computerized physician order entry. And as a part of that standard, we developed a flight simulator to evaluate electronic health record systems in actual operation. So when a hospital puts one in, we developed a flight simulator that can come into that hospital and say, gee, now that it's installed and operating, how good of a job is it really doing at improving medication safety? And that led to the publication of this study, which looked at basically testing, stress testing installed electronic health record systems with computerized physician order entry in place, stress testing them with problematic orders to see in operation how many of these problematic orders got picked up. And what we found was that there was enormous variability from hospital to hospital in how well their operational system picked up these stress tests, if you will, of medication safety problems. And indeed, this stress test included certain orders that would likely lead to a death of a patient. And what we found is about half the time those orders were picked up in operational systems. And that's the point, that just installing these systems doesn't automatically lead to an improvement in safety. And one of the most dramatic findings in this study was when we broke out the performance of hospitals with their installed electronic health record systems by vendor, and those are the vertical columns here, you see enormous variability in how the same vendor's product behaved in different hospitals. Enormous variability. And the little dot on the left is a homegrown system in Boston. The rest of the dots are all commercial systems. Look at the variability there. And the reason there's so much variability there is every hospital does it differently. And when you do it differently, it has impacts on medication safety improvement. This is why we've had challenges, I think, in maximizing the impact with these particular technologies. And our panel will talk about this, but that particular flight simulation technology is going to be expanded and broadened to lots of aspects of the electronic health record. Chuck Denham has really been driving that, and I think it'll be a very useful tool to help in improving medication safety. The IOM report I cited was asked to look at where we are in terms of patient safety 12 years on from the IOM report to Errors Human, and we focused on 3 big studies to answer that question. One was an Office of the Inspector General study of safety in the Medicare population. Another was a study in the New England Journal of patient safety at the state level in North Carolina. And then the last one was a study of safety in 3 exemplar health systems. And basically, what was found in the Medicare study was that we still have a lot of adverse events occurring in Medicare patients. And what was found in the statewide study was that we still have challenges in improving. And if we look at the Medicare study, it found that about 27% of all Medicare enrollees who go into a hospital experience an adverse event. Medication safety problems were the #1 issue in this recent study. In the study in North Carolina, they looked at a very similar method of measuring safety and found not a whole lot of improvement over a 5-year period of intense focus on safety in that state. And then finally, this was a study of safety in 3 exemplar health systems. What was interesting about those health systems is they all had implemented all the medication safety technology we've talked about. They all had CPOE, barcoding, they had robotic dispensing, they had it all. And in those hospitals, we found adverse events occurred in almost 1/3 of the patients. And not surprisingly, you can see medication-related was #1. So medication-related safety still is the #1 issue in our healthcare system, despite all the technology we've thrown at it. But one of the most important outcomes of that study was how good we do at detecting patient safety in hospitals with different methods of detection. So the method of detection on the left was the IHI Global Trigger Tool. An external group of reviewers came into these 3 hospitals, studied their charts intensively for safety problems. That's the one on the left. The one in the middle was the hospitals coding their medical records for complications using the ARC PSIs. And the one on the right was voluntary reporting systems in each of those 3 healthcare systems. And what was found, interestingly enough, is out of about 393 adverse events that were detected, only 4 were picked up with voluntary reporting. The reason that's important is this panel is going to talk a lot about data that comes from voluntary reporting. And if you want a perspective, voluntary reporting picks up about 5 to 8% of all the safety problems in medication safety. So when you hear those numbers, you're talking about a small percentage. The other point I think of this study is that administrative coding and data sets miss about 90% of safety problems. So we have clearly a ways to go on, if you will, measurement. But here's data from a reporting system at the state level in Pennsylvania, as well as the MedMarX system, showing some example of how commonly medication errors lead to deaths. Remember, this is voluntary reporting, so it's underestimating the problem. So moving forward, and I'm going to end with this, what we said at the Institute of Medicine is we do need to take a bit of a different direction with respect to technology. We have to learn how to design it much more effectively. We have to learn how to optimize it continually, and we must test it in actual operation to make sure that it's doing what it's designed to do. I've been in a number of hospitals where we brought the flight simulator that Chuck Denham and I work on and put some orders into a hospital's computerized patient order entry system and watched those fatal orders run all the way through the system and would have been administered if we didn't stop it. How could that happen? These are very complex systems that are changing on a daily basis. Updates are going on all the time, and what people don't realize is those updates can disable critical safety checks. And if you're not testing in an ongoing fashion, as we do in other industries, you just don't know what's really going on. So I will finish with this. At the Institute of Medicine, in both our report on HIT and patient safety and a brand new report on better care and lower costs, we call for the adoption of a new approach to integrate technology and non-technology approaches called the socio-technical model. That when we see systems that are optimized for safety, they don't just have good software, they have good people, good process, good organization, and a healthy external environment. So going forward, we're going to talk a lot about this on our panel about how the different pieces of this might fit together in terms of improving medication safety. So I will stop there, and then we can move on to questions for our panelists. So we're going to start with a focus on intravenous medication safety, a key area in all of our studies of medication safety of risk. And we're going to start with Nate Sims, who's spent his life in this area, and that's an understatement, both his wakeful and non-wakeful life, if I had to guess. And Nate, your area of expertise is drug infusion pumps in critical care, anesthesia, cancer care. What is the infusion safety problem, and is the trend improving, staying the same, or worsening?
So thanks, Dave, for your question, and thanks to Joe and Sarah and Mike and Chuck and the planning committee and everybody here, because this is a fabulous event. I'm going to shamelessly use notes because I'm going to present right now some harm incidence data that has never been presented before, with all humility as to its usefulness, but I need the notes. There's really two phases of the performance gap, 2010 and now. In April of 2010, the US FDA made drug infusion safety a front page item by announcing a mandatory order to industry to destroy and to replace 1/5 of the 1 million drug infusion pumps in the United States on the argument that they were unsafe to use. The FDA stated that in the 5-year period prior to 2010, there were about 700 preventable patient deaths due to pump problems, such as the pump randomly shutting off. And that there had been 56,000 incidents reported to the MAUDE database. MAUDE database stands for Manufacturer and Device and User Facility Device Experience. It's a voluntary reporting system, though some reports are mandatory if there's serious harm or death. 56,000 incidents in 5 years. And that manufacturers themselves had had over 85 voluntary recalls of their devices during that 5-year period. The FDA said that the way in which the devices were designed and approved for sale needed radical change, and a complete revision of the 510(k) process has been released in guidance. So in the 3 years since April of 2010, over $2 billion has been spent by industry and by the effort of hospitals to get rid of those obsolete devices and to put new second-generation smart pumps and other technologies in place. In parallel, and particularly with the compounding crisis that's been in the public news, there's a huge changes occurring in the pharmacies in terms of how drugs are sourced, mixed, verified and labeled with a pedigree that is robust and that helps users program infusion devices. And on the provider side, I'd say out of 5,000 hospitals in the US, there's about a dozen who have wired together the cluster of technologies you mentioned into a reasonably seamless digital pathway between the synapse of the provider that's making the med order and the bloodstream of the patient. 5 out of 5,000 is a great start, but it's not enough. So I see the glass as half full.
And Nat, What is the state of the performance gap for infusion safety right now? We've clearly made some progress,
So
but we have a ways to go.
There you go. And as Gibson famously said, the future is here. It's just not evenly distributed. So the hospitals that are still struggling to implement and harmonize these safety technologies have more work to do. Those hospitals that have not started to implement the safety technologies you listed need to begin fast, because I think payment is soon going to be tied to success in metrics derived from those implementations. That's a hugely important point. In terms of citing particular luminary institutions, it's common to mention Lancaster Hospital in Lancaster, Pennsylvania, being one of the first hospitals that can automatically program a drug infusion pump over the wireless network. It's fabulous. And Intermountain Healthcare has a unique homegrown informatics-centric system which is breathtaking and deserves a visit. There's actually videos available to see it. And Partners Healthcare in Boston since 2005 has had an incredibly ambitious program of comprehensive implementation of all that we've talked about. But here come the data. In terms of actual harm injury trends, we do not have, though Mike Cohen is helping to build, a good incident and harm reporting system for infusion pump problems. Pat Baird, an engineer who works for Baxter Healthcare, is the best person I know at being able to go into the massive MAUDE database and pull out actual useful data. And I'm going to present it. This is from yesterday, covering the January 1st of 2007 until the last day of 2012. And it's divided into three categories: insulin pumps, large volume pumps, and PCA pumps. Insulin pumps is quite a scary topic. We're not going there today. There are 350,000 insulin pumps in the US. There have been 657 deaths in 6 years. That's 110 deaths per year, 10 deaths per month. A trend of improvement that Pat notes down from, well, we'll just leave it there. In large volume pumps, the common ones, the bag pumps, the pumps that are on a pole, there are about 1 million of them in the US, each doing 200 infusions a year, so that's 200 million infusions. There have been reported 119 deaths due to pump failure in 6 years, 10 a year or more, and about at the rate of 2 per month, continuing up through last month. No overall trend in improvement. And in terms of injuries, non-death harm events, there are about 10 to 20 reported injuries every month on large volume pumps. In PCA pumps, the third category, there are about 200,000 PCA pumps in the US, 53 mandatory reported deaths in 6 years, 10 a year, about 1 a month, and a trend which is looking better.
So you've been involved in this area for a long time. So if a hospital's struggling with how do I improve my infusion-related safety, what would you say is the recipe that you would tell them?
Terrific question, and I think the recipe is extremely clear, which is why we love this conference, which is about recipes. And you've already hinted at it. I'm just going to restate it. I say there are 5 core elements to the recipe. The first recipe is electronic medication ordering with decision support, typically called CPOE. Second is a host of dramatic hospital pharmacy improvements, including automation, surveillance of IV room drug mixing, and assurance of drug compounding, and better labeling that just helps providers know how to program the devices. The third key element is often called EMAR or BCMA, electronic medication administration record with barcoding that assures the 5 rights and can be modified to assure point of care nursing second checks and patient assessment with forcing functions, something we're doing a lot of. The fourth is moving from smart infusion pumps to intelligent infusion pumps. Smart pumps have a customized hospital formulary with generic guidance for each drug. Intelligent pumps means the pump is on the wireless network, and it's actually reconciling against the specific medication order for that patient, a huge advance. And the fifth one, the one we're actually most excited about right now, is patient and family involvement in the safety assurance process. One thing we want to discuss in the breakout session, and Narendra and I, we think we have an app for that.
I mean, you could be coined as the inventor of the smart pump. Is there an event that got you involved in this particular area?
So there is a particular event that I still can't forget from 1986. It's a near-miss event. And in 1986, I was a pediatric cardiac anesthesiologist at Mass General, and we had a one-day-old baby with critical congenital heart disease who needed surgery. In those days, you needed surgery to do an atrial septostomy, and they needed to be stabilized with an alprostadil infusion to keep the ductus open for the 24 hours. And the baby was simply not getting pinker. And we sort of went back and looked at the math of the mixing of the drug and realized there was a 60-fold underdosing of that particular baby. We caught the error, the baby did fine, but something about looking at that one-day-old baby and me saying to myself, you know, what did this baby could have a full 80-year lifespan, you know, if we first do no harm. And secondly, kind of the baby is defenseless. What did the baby do to deserve having this intrude on their life at 24 hours of life? And that really was the motivation to say, I'm going to step out of my job description. I'm going to do whatever it takes to work with people who can make better pumps that can help make these calculations. Computers are good at that.
So what does this mean for a nurse on the front lines of care?
Well, I mean, I think I think most people have an image of how smart pumps work. Basically, the mental model is a caregiver takes a properly mixed, properly labeled bag or syringe of drug that they intend to give the patient. The pump recognizes the drug name and strength. It pulls up the appropriate delivery parameters for the care location and the type of the patient. The critical parameters are automatically filled into the programming screen based on the hospital's approved practices that are built into that drug library. If the dose rate has to be manually entered through a keypad, the dose rate is sanity checked against limits or even against the titration limits for that particular patient. And in theory, errors are prevented before that they occur. And in advanced hospitals, there's more automation.
So where does it go from here?
Well, I think the question really, what's the infusion pump of the future look like? And here I'm talking the second or third horizon. But I truly believe, and I've already seen, and some folks in my lab are working on, a concept for an infusion pump which is really like a smartphone. It is wirelessly communicating with something that's kind of like a bump on the tubing that's controlling the flow rate, the pumping subsystem. The smartphone is handling the identity of the drug, the identity of the patient and caregiver, the med order, and it has two forms of user interface, a provider-facing user interface that helps the nurse or the physician program the pump, but a patient-centered user interface so they can look at the screen and say, and understand what's happening. So that's my
Great
vision.
Thanks, Nate. Next to Michael Cohen, Mike, you at ISMP probably have the greatest storehouse of medication safety information ever created in human history, and you guys have been doing this for decades. Yeah. So I guess my question for you is, how has the hospital view of medication errors changed over time, if you look back over the last decades that you've been working on?
It's a mixed bag, I would say, and you probably got a sense for that earlier with the other speakers. But, you know, on the one hand, no question, hospitals have less focus on the individuals when they're involved in errors, and more so on recognizing that, you know, when errors happen, they're multifactorial. Many different contributing factors. I've never reviewed one error in all the time I've been doing this that only one thing went wrong. So I think that's a big thing. And people recognize the system-based causes of the errors more than they did when we first started. They used to count errors by counting up the number of incident reports, you know, and comparing it to the number of doses of medication, which I don't see that happening anymore as well. On the other hand, I have to say that we are still seeing, despite attempts at, just culture training and the things that we have focused on, not we, but everyone, we still see situations where individuals are blamed by the media, sometimes by the legal system. Dr. Denham and I have worked with individuals that have lost their job. They've been brought before the state board, lost their licenses. In one case more recently, a pharmacist went to prison, and it was just a horrible situation. So all those things are still out there. Not as bad, I think. I will say this, if you're looking for something health policy-wise, and this is something other people have probably heard me say multiple times, I get very disturbed when I see the exact same problem that we've published multiple times. This morning, I went on my email, 719 people are at risk of HIV and other bloodborne pathogens, hepatitis B, hepatitis C, whatever, because they reused insulin pens on multiple patients, just by changing the needle, thinking, no big deal. Well, we put out 3 hazard alerts. FDA did a video on it. The CDC earlier this year, or earlier in 2012, came out with an alert. And if you're looking for a health policy thing, I don't think we should tolerate things like this anymore. We need some patient safety organization. I don't know what you want to call them. In England they had the UK, had the National Patient Safety Agency, and Joint Commission has touched on this with their National Patient Safety Goals, where they set up a patient safety standard. No KCL on the nursing units, period. If our surveyors come in and we see vials of the concentrate, well, guess what? We haven't had a potassium chloride death since they did that, and I think that was like 2000 or 2001 in an accredited hospital. Not one has been reported. I haven't read about them in the paper or anything. And I think that is something that we need. So insulin pens, we're going to send out an alert in the next few days, and here's the 5th time somebody has had their surgical wound irrigated with glacial acetic acid. Now, how does that happen? It's 99%. Vinegar's 5%. That's about what they normally want, maybe a little bit more as an antibacterial. So I really think there needs to be a focus on high-level types of problems like this that absolutely shouldn't happen, where we bring oversight agencies to bear so that these issues are addressed. And that hasn't happened. And when I talk to the leadership about it, oh, there's too many things to do, there's too much, I can't buy that. And it's been very frustrating. I've been doing this since 1975. And that's a long time to see these things continue. And I could give you a handful of major issues like that continue to happen. We heard about a bunch of them this morning, with post-op opioids, PCA by proxy. These things still happen. We still get reported.
We tolerate a lot of things other industries wouldn't put up with.
Yeah. So
clearly, has the epidemiology of medication errors changed with all the technology we've thrown out?
Has the epidemiology changed? I think it's been very helpful. I don't know how well it's been studied, but for example, the smart infusion devices, I think if they're used properly, I think we need to do more standardization. I'd like to touch on that maybe at some point. I think they can be very helpful. I really like the barcoded bedside scanning of medications. And our number one problem is patient identification issues. Wrong patient errors. And it happens not just at the bedside, it happens in the pharmacy too. And it happens elsewhere, even in the admissions office, where wrong information is coded. So I think it can be very helpful to, use the technology that we have. And certainly with, the monitoring that we were talking about this morning. Absolutely.
So in today's world, what are the most serious medication administration errors you see?
I think it depends on what you're looking at. I mean, you know, medication-wise, it has been absolutely consistent. Insulin is at the top of the list. In Pennsylvania data, as well as surveys that we've done, and that goes back into the late 1980s, where we came up with the concept of high alert drugs. This is a small group of drugs, like the 80-20 rule, you know, where the focus is on those drugs that are most likely to injure patients. Insulin would be up there, absolutely opioids, absolutely neuromuscular blockers, and you know, and on and on and on. And in fact, you know, Dan Budnitz came out with an article last year in New England Journal where he looked at readmissions in the elderly Medicare patients, and you know what? It almost matched identically the top 10 list that we had for high alert drugs. So that's important to recognize.
As we move more and more surgery out of the hospital into ambulatory surgery centers and then into physicians' offices, what are the big medication safety issues there that you see?
Actually, we do cover in Pennsylvania, and we're the organization that reviews all the medication error reports. It's not just hospitals, it is ambulatory surgical centers. It's other ambulatory sites as well. One of the issues with that we do see in ambulatory surgical centers, for example, is incidents involving not properly monitoring the patient during the surgery. The check systems that are used. Sometimes we see, wrong medications. The whole issue with confirming that the right medication is being prepared. That shows up a lot of times where there are errors as a result of that. But we really haven't had much opportunity to study group practice facilities, physician offices, because we don't get reports. A lot of it is going to be prescribing issues, obviously, which sometimes don't get picked up as the errors that they are. But we need to know more about what's going on there as well.
We don't seem to know much about going on there, but more and more serious surgery seems to be headed that way.
Yeah.
What about the issue of drug shortages and the impact it has on medication safety,
Well,
which seems to be more and more common all the time?
Yeah, we get more complaints on that than probably anything right now. It has been so serious. And it hasn't gotten a heck of a lot better. There has been some action. There was a new law that was actually signed. The Prescription Drug User Fee Amendment included some drug shortage legislation, and it's helped. It gives FDA the authority to require drug companies to give 6 months notice before they stop manufacturing a drug for whatever reason, if they voluntarily decide to do that. And they may have helped a little bit. We're also seeing some importation. But when we looked at the errors at the end of last year, we had well over 200. We had well over 200 in 2011 as well. And the really sad thing is, if you looked at them on a cumulative basis, at the end of last year, the total number of drug shortages, both new ones and the current ones that haven't been resolved, were higher than they have ever been. And it's major, major drugs. We're in anesthesia, succinylcholine. We've had the propofol shortage. I'm not getting my colonoscopy until I know I can get my propofol, by the way. We've had quite a few other absolutely mainstay drugs. And in the area of drug shortages, opioids, we've had problems at one point getting fentanyl, and more recently than that, we couldn't get morphine, and we had to substitute that with hydromorphone. And we had a bunch of errors that were reported where people either confused the names, hydromorphone and morphine, or really didn't understand the potency difference between those drugs, which is about 7-fold, and they would prescribe hydromorphone in the morphine dose. We also just had, not too long ago, we gave a program where with potassium acetate, we weren't able to get that, and a lot of the other electrolytes too. And one of the issues is that hospitals aren't prepared sometimes for a drug shortage. They bring a new drug in and they don't, we have a lot of technology now. You have the barcode system, CPOE, the pharmacy system, the automated dispensing cabinets, and so on. They don't necessarily talk to each other. That means that when you bring a new drug concentration in, for example, you've got to have somebody manually go and make all these changes for all this technology. And that wasn't done in this one location. We had over 100 patients get overdosed with potassium acetate because of the concentration change that wasn't changed in the software. So that's a major issue.
Thanks, Mike. Let's move on to Narendra Kini. Narendra, how would you categorize the type of medication errors that can be made from a provider point of view?
Thank you, Dave. First of all, let me quickly thank Joe and the team again for putting this together, but I want to reserve a special thanks to the families that came here and talked about their loved ones. As a pediatrician, that's really motivating. I mean, this is the real reason why we're here, and hopefully something will come out of this that will make that never happen again. Talking about kinds of errors related to providers, I think there are two categories, and I'll try to stay from the perspective of CEO here and focus on process and technology, despite my inclination to go clinical. The first one is really the content issues. That would be what Lily discovered yesterday when she said, I don't know, just a pure lack of understanding of pathophysiology. That would be the first type of issue you would deal with. The second really comes down to handoff or omission errors. And it's fascinating that even now, handoffs are not standardized. You'd imagine any unit today, different providers hand off to their own type, but there's not a universal handoff with the same exact set of data that goes from one to the other during the handoff, and it's definitely not in the electronic medical record. The third part is even if there is a handoff, the area that would be of concern is not sometimes highlighted. So those are the content types of issues we deal with providers. The second big category is really related to cognitive challenges. And first would be the so-called overload related to hunting and gathering that Lily mentioned. I like that term. I'd add a second term, which would be the click fatigue nowadays. Doesn't matter what brand of electronic medical record you choose, there is definitely click fatigue, and this is a distractor in terms of what they're supposed to do in achieving the outcome. And the second type of cognitive overload is really the distraction in the environment where people are responding to patterns from multiple patients at a time and might actually miss a particular pattern that would lead to an error occurring. So those are the basic two categories related to providers. And each of these, unfortunately, has a specific recipe. One does not apply to all.
And the process challenges in implementing these programs?
The process challenges, there are very significant process challenges that we see. I'd like to, if you want to take the same question of medication safety or intravenous medication, the medication cycle itself is really a set of processes. That's the order phase, it's the prepare phase, then the transport phase, the verify, administer phase, and finally the monitor phase. Each of these has specific processes underlying it. And if you then put something like CPOE, we call that computerized provider order entry, it does not address some of these phases. Unless there's reliable processes underlying each phase, there's likely to be a defect, and that might lead to the actual error. The other issue is, if you look at us, and I've put in about 14 of these systems, I'd like an honest appraisal here. When we put in CPOE systems, for example, doctors will put in their orders, their committees that then decide these order sets depending on specialty. But we know there's variation even in each section. So there's multiple order sets for the same diagnosis, and even the sequence with which they're installed when you go live is variant. Therefore, the CPOE system is likely to come with variation embedded within it, leading to some of these orders. Lastly, the processes of recognition. Even today, you have multiple cockpits, the IV pump, the physiologic monitor, the ventilator. And it's amazing that in 2013, you can integrate all of this into a single glass cockpit for a provider to look in one place at a time. But the fact that they have to stare at different screens to achieve the same information, itself a process issue that we've chosen not to handle up till now.
Why hasn't CPOE been the magical bullet we thought it was going to be?
Well, I think, again, there's a misnomer. CPOE is one aspect of the entire technology solution. Provider order entry depends on certain ancillary technologies being installed at the same time. And I think Nat said it best, unless you have a very robust preparation in the pharmacy, standardizing the formulary, unit dose preparations, the capability to install barcodes at the same time you put in the CPOE, advanced monitoring and surveillance, once the CPO is installed, it really loses the impact it has. The second part is CPO is dependent on recognition of the fact that your care process is embedded within it. And even in our institution, our nursing committees put together the care plans. Our doctor committees put together the order set plans. Sometimes those don't correlate to each other. And I don't remember us cross-fertilizing nursing committees that did care plans with doctors and vice versa. When you understand what that happens, when all this comes to be and you computerize it, there are obvious defects in the process. So we have not seen the real impact, A, because all of the ancillary technologies have not been installed to get the impact. And second, the processes that are required to install these in a standardized manner are still found to be extremely challenging.
So if a hospital wants to error-proof a process like the medication use process, what technology considerations would you advise them to think about?
Let's talk about just challenges that we face in that process. First, I think biomedical department is today essentially an information technology department, but I will tell you in most hospitals biomed does not report to IT. So there are structural silo issues, and in my case, we have made biomed report to IT. You cannot standardize devices and have them interoperable with your core CDR unless there's a link between those two departments. So that's the first issue, I would say. The second is, although it is wonderful for providers to be involved in choosing devices, there's a back end. Are these interoperable? Will they send the data? And can you subject them to analysis? If you choose devices by unit, there is a problem in terms of the ultimate data being extracted and used for patient safety purposes. So standardization of devices by device type would be the second issue. The third is assuring interoperability with the EMR. That's easier said than done because these choices are made independently most of the time. But our, again, opinion and our experience is unless you do these things together, there's a challenge. A couple more areas. The data model and data warehouse design that should come with these is also found to be something that you do after the install. I think having a data warehouse that is ready to accept all of the data, subjected again to aggregation and reporting, should be done at the same time that you pick the EMR and you pick your devices. Lastly, appropriate wireless connectivity. It seems simple, but a lot of these devices, when you buy them and you start to install them, you begin to find gaps in connectivity. And that's because the basic infrastructure is not ready for the devices, and you lose that safety guardrail that should have come with those devices. So these are steps I think we take, and we've done them, will assure that you can get a reasonable technological solution.
Great, thanks, Narendra. Let's move on to Rick Boothman. Rick, you really sort of have led the nation, I think, in how you handle mistakes. Could you share a little bit with us about your approach and how you handle mistakes at the University of Michigan?
Thanks. I guess I got very fundamental. I'm a lawyer, and you notice nobody sat on the same couch with me. But lawyers, and I'm proud to say, we are a service profession. And yet after 22 years of representing some of the finest healthcare institutions in the Midwest, I realized that none of my clients asked me what they should have learned from the cases I handled. More importantly, I recognized that I did my clients no favors by defending care that should not be defended. We didn't need a jury to tell us what was good care and bad care. So I felt the most important thing contribution that I could make was to come to the University of Michigan and say, it's okay to be honest. We don't need to indulge this defensiveness. It's okay to talk about the real mistakes, because what I recognized was not only was it expensive, both financially and emotionally, to everybody concerned, more importantly, I was a barrier to patient safety. By defending care that shouldn't be defended, we were shutting down all the discussions. And much has been made of disclosure saves money, apology saves money in medical malpractice, but the more important and salient lesson is that first disclosure is the one we make to ourselves. you can't make progress until you admit you have a problem. And I was participating in a whole generations of denial, frankly, about medical injuries and genuine medical errors. So I didn't do very much other than be permissive. I showed our organization, and I hope the country, that the sky does not fall in, and all of this business of blaming lawyers for why we can't talk openly about this is nonsense. It's just an excuse.
In many hospitals, their risk management sort of separated from everything else, separated from quality and even patient relations. You sort of dispensed with that and created an Office of Safety. Why'd you do that, and what's been the impact?
Well, first I need to say that's not just me. In fact, it's Dr. Skip Campbell. I'm blessed with our first CMO, who is an Eisenberg winner in patient safety, and he's passionate as can be. He convened a team that recognized really three things that I think are pretty important for us to talk about. One, as an organization, we had proven to be ineffective at addressing patient safety issues. Secondly, the corporate fragmentation that existed in our organization was getting in the way and impeding any progress. And thirdly, there was not good leadership accountability. So what do I mean by that? Well, first, with regard to the ineffectiveness, we looked at 10 years of action lists just from event reviews alone. Fully 80% of action lists resulted in no change over 10 years. That's idiotic. We were spending a lot of time in processes that we proved over 10 years didn't work. Secondly, the fragmentation was a problem. Patient relations would get complaints, I shouldn't pay this bill because I got an infection after surgery, and they would see it as a billing problem, not as an infection problem. That fragmentation got in the way. More importantly is the accountability. Dr. Zeltner last night made reference to something that really struck home, and it was an offhanded comment. He said, politicians don't talk to him about patient safety, but they will talk about the costs. You only have to spend 5 minutes with people like Helen Haskell or Patty Skolnick to walk away thinking, my God, patience in this space is not a virtue. There is a sense of urgency that we are lacking, and we are lacking for maybe a whole host of reasons. You should have probably a psychologist up here, not an old lawyer. But that failure to recognize the urgency of this issue and to have it permeate everything that we do every day, even for people like me on the fringe as a lawyer supporting this, I think is the biggest failure. The largest failure that we have isn't systems problems or failing to adopt technology. It's indifference. And we see that over and over and over. So I love engineers. My father-in-law is an engineer. I love how the gears work, even in his 85-year-old mind. But all of the technologies and all of the processes won't mean anything if we lack the will to do something. And the antidote to that lack of will, I think, is a sense of accountability. So what did Dr. Campbell and we design? Well, we redesigned this system to put the leaders front and center. Just a small example, our event review teams now will produce action lists, and those action lists don't go to the quality improvement department. They go to the leadership who have 24 hours to say yay or nay on the things that are on that action list. And if they say they can't do it, they have to explain why. We then go to a plan B and we keep ratcheting down. Dr. Campbell has redesigned the whole organizational structure so that prioritization will be directly in the hands of the leaders on a monthly basis. So basically what we've done is we've said to ourselves, you can't fix a problem you don't know exists. We know the limitations of voluntary reporting. The first box, if you think in terms of 4 boxes, the first box is collection, and it's got to be a push and pull. We can't rely on incident reports because, as you said, 8% of patient safety issues come forward with incident reports alone. So we've got to concentrate on and reorganize around the idea of spreading a broad net to capture all of those pockets of data that we all have and we don't exploit. The second thing, though, is once you establish that fire hose, you've got to make sense of it. You can't try to fix everything at once. How do we analyze and prioritize? That's our second box, our organizational box. Analyze and prioritize what's important, because at our hospital, we still worry more about what is important to U.S. News and World Report than we worry about what's important to the University of Michigan Health System. The third box is just as important. Having established what's priority, we work in an interdigitated environment where you can't whack-a-mole here without affecting one there. We've got to both fix and measure. So that third box for us is robust, fix and measure. And the last one may be the most important. We should be able to grab a nurse off of any floor and ask him or her, quick, what are the 10 priorities of our hospital as far as safety and quality? Today, they don't even know that we have an organized effort to do that. So the last box has got to be communication. And I believe that if you set up a system that is built around those 4 boxes, we will create a positive spiral, because people will see good things coming of reporting into the system, and that 8% will grow like crazy.
So you've created an office of safety that you have to budget for. Most hospitals have not, and that's a big challenge for most hospitals. How do we budget for safety?
Well, actually, that's the easiest of all. If you save one birth trauma case, you pay for the whole department. That is a complete no-brainer. I have no patience when people talk about the cost of safety and quality. We've truncated, because we recognize the continuum between comfortable patient, rich quality patient care and disaster. We've recognized that continuum, and we've truncated patient safety, quality improvement, risk management, all in a singular office of the Office of Clinical Safety. It was to be called the Office of Patient Safety, and one morning I recognized that the acronym was OOPS, and nobody took it seriously.
Clever, clever. But then again,
Right there.
well, we'll move on. Thanks very much, Rick. So Josh Adler. Josh, let's start. You're a chief medical officer of a large academic medical center. What do you see as the most readily addressable intervention around medication safety at your organization?
So I'll answer that sort of in context of sort of Nat previously outlining the various places where we can intervene to improve medication safety and the various technologies available. It's a little bit daunting to think as an organization we're going to take all of that on at once. So where might you start? And I think from a yield standpoint, if I were starting from scratch, I would start with barcode med administration. And the reason for that is it is absolutely true that digitation of all of these safety systems is critically necessary to get transformational change. There's no doubt. You can get incremental change with barcode med administration done well all by itself. And so there's value to an organization of taking on one thing, reducing in a real way the number of errors due to that one thing, knowing that you will still have errors due to preparation, errors due to improper ordering, et cetera. The other reason I think that there's a sort of an epiphenomenon, barcode med administration is a big deal. It fundamentally changes the job of every nurse and most pharmacists. And it's visible to the whole organization. So it is a way for an organization to say, this is really important. We're going to do something about safety in medication delivery, and it will be visible. So it's a beginning of a culture change event.
I mean, obviously, we've imposed a lot on frontline clinicians with CPOE, with barcode administration, and even with, dare I mention its name, medication reconciliation, right? So what's been your challenge in implementing something like medication reconciliation, which has enormous impact on process, right? Both the beginning of the process, through it, and at the end. I hear more clinicians complaining about that than almost anything else.
You decided to ask me the thing that I know for sure we are not doing very well. So medication reconciliation, a critically important step in safe medication administration practices. The first, number one thing for any of these, but certainly applies to MedRec, is establishing in your own organization the burning platform. I mean, we're doing that right here, or it was already done for all of you, otherwise you wouldn't be here, that there really is a problem. The next and harder step is, and the solution to that problem is X. So one of the challenges with medication reconciliation in particular is getting enough people on board to believe that we have problem A and solution A will deal with problem A. So that is a really important step that you as an organization have to take on, and we struggle with this. We do, because we still don't have uniform belief that the processes of getting an admission med list accurate, making sure medications on transfer are the same as they were or need to be reconciled before the transfer, and then discharge, oh my goodness. So I think getting your organization to buy the burning platform is critical. And then if you can do that, you're still not home, because then you need to engage. I think that the nursing leadership panel yesterday really said this well. You have to actually engage the users in the design of whatever technology you're using, because you're going to change their job. Just as an example of when you put in an EMR, you change every single person's job in your organization, every one. And if you're going to change everybody's job, you sure as heck better involve them in how that job change is going to work. So I think real early engagement with the frontline users on, this is what we're trying to do, here's the technology we have available, how do we adapt this to make this work for you? And if you can do all of those things, then you still need to do a few other things. First, you have to measure that you're actually doing what you said you would do, and that requires coming up with a bunch of surrogate endpoints. You can't rely on just saying, okay, we've put in this system, we think everybody's using it, now we'll wait to see what our error rate is. That's a complete recipe for failure. If you've decided that every patient on admission needs to have their medications reconciled by a pharmacy technician or a pharmacist, then you sure as heck better be down there watching to see that that is happening. Because if that's not happening, you know that the system's not going to work. And that, I think, is a place where we've all failed in any, whether it's barcode med administration, smart pump use, or MedRec.
Great. Thanks, Josh. Well, I have no more questions for the panelists. I thought I might just finish where we started. In our IOM report on HIT and patient safety, we thought measurement was absolutely critical, Josh, as you just said, that we really don't have good measurement systems to know where we're going. We rely on incident reports, which we now know massively underestimate the problem. So in terms of moving forward, we really must focus on better measurement systems. The challenge is how we leverage all the HIT we put in place to improve our measurement. The other thing we focused on at the Institute of Medicine in our socio-technical model was the role of culture. And that culture is the final barrier for both for socio and technical implementations. And that ultimately we're going to learn what the Navy has learned in other, if you will, high-risk industries, that if you don't address culture, you can have the best technology in the world, the best people, the best organization, the best process, you're still not going to arrive. So with that, I'd like to thank all our panelists for a wonderful session, and we will give some time back.